Hi, thank you, Ariel. I presume you can hear and see my slides. Can you?
Yeah, sure.
Okay, thank you very much. It's a very hard act to follow after Professor Anna Begonia sort of presented this very beautiful, introduction and outlay into the management of the ischemic limb. So I'm going to focus very much on diabetic foot attack, something that I'm really sort of keen on promoting around, and slightly going to go beyond what you allowed me to do, Ariel, is talk not only about ischemic and neuroischemic, but also perhaps any diabetic foot infection sort of attack. And I know yesterday Jose Lazaro Martinez and Anand Pillai did a little bit of on infections, but hopefully I can reinforce some of those concepts and talk a little bit more about our work here at King's. I work at the Mike Edmonds Foot Unit here at King's College London. Just to let you know, most of the images are quite graphic, but I'm sure you all will be able to tolerate these. But I'm a physician, I'm not a surgeon, and a lot of the conversation here is from the eyes of a physician who does diabetic foot all the time. And we know the three main villains, the neuropathy, the arterial disease, the foot deformities, can lead to ulceration. And then our patients have a host of complications, lots of them. I mean, it's unusual to see a patient with just three of these initial issues. They usually have one or more of these, and really makes it very difficult and often challenging to manage. And despite a whole lot of talk, we still lose a limb every 20 seconds. And in the United Kingdom, we spend in excess of $1 billion. I think that's an underestimate what the figures we have. So a huge amounts of money spent on managing diabetic foot disease. And there is this emerging concept now that we talk about, a diabetic foot attack, which is not necessarily absolutely a new concept, but it sort of represents one of the most devastating presentations when it comes to diabetic foot disease, either severe progressive infective necrosis, which could escalate over hours to threaten the limb. As such, as you know, many societies have taken on the baton, and they're promoting foot attack in diabetes. But of course, when I mean about the foot, the philosophy really is that severe infection, that sense of urgency, and that sense of really sinister potential, which could, if ignored, lead to sort of urgent amputation, and a reinforcement of the concept that time is tissue, a bit like how our surgeons, our cardiologists have done with heart attack, and now the neurologists talk about in terms of cardiovascular disease, really this concept as time is tissue. Now, typically, a diabetic foot attack would be a infective one, as such, but not just an infective foot attack. You can have patient presenting with extreme vascular disease, and this might be the first time they're presenting, and that could also be that sort of end-stage vascular disease also represent a foot attack. And we must not forget Charcot-neuropathy. The initial presentation is so important, and if you can get on top of it, we can have a limb with no deformity. This, perhaps the typical infective attack, is the most common. And my colleague, Mike Edmonds, who's sort of the doyen of diabetic foot management, often says, Prash, you can lose a limb overnight from infection. It does not happen with vascular disease. It does not happen from any other condition, but severe infection can drive that. And this is, really this rapid necrosis that can sort of take, and it takes precedence over infection. This is one of my patients with both severe infection and arterial disease. But at that time, as you know, the arterial disease has been there for some time. What has changed for her over the last 24 hours is the infection. And it's the infection that needs that sort of primacy, that primary control, either with antibiotics or surgery, or at times in such situations, both. And of course, you have the the more atypical ischemic events where infection isn't the big thing, but you have really critical limb ischemia, and patients presenting in this sort of pathway, almost what you call chronic limb threatening ischemia. On that spectrum, they're presenting sort of late down there, beyond the tissue loss stage, where we don't have too much to wait with, and that certainly is also a critical area. Charcot I've just spoken about. This is one of my patients. She kicked her leg. The leg was swollen for about a few days. She did go to the emergency department, as you can see on the picture over here, a perfectly normal x-ray. So they said you must have sprained your leg, didn't offload it, and you can see a month later she's been sent to the foot clinic with this massive dislocation and ongoing swelling, asking maybe her cellulitis has not got better. What can you suggest? The reality is that somewhere down the line, someone missed a chance to protect this leg and avoid the situation. So a foot attack can present very differently, but it's important that we recognize it, get an early referral to hospital, and we need assessment by a specialist team. And to do that, we need to have very good clinical pathways in hospitals that are designed to take people with a severe infection or an acute Charcot foot. Our pathway at King's is well documented. It's in our paper. I have the reference on the sides, and we really focus on urgent infection control for those who are severely infected, planning surgery, and if needed, taking back to theater in 48 to 72 hours, alongside a really intensive wound care phase while they are in hospital, along with rehabilitation and physiotherapy to try and make the best of a very difficult situation. And we've sort of published on the importance of getting good debridement. I think often many centers, at times even ours, we don't get it right. Good debridement is very important. That will allow to control infection very well, and we should not hesitate to get good debridement. This is a good example. A large abscess that was left with a huge amount of erythema, and these are our red, amber, green zones. Green means possibly healthy tissue, amber still probably infected, and red is the key zone. And you can see debriding it fully can allow us to salvage limb. Now, this limb shape is not perfect, and the management of these patients does not stop over here. They still need a lot of work to protect this from re-ulcerating, but you can achieve limb salvage to begin with, and it's addressing infection as high as possible, as up tracking to try and get rid of all the tendon infection. The tendons are the highways of infection passage, and it's important to get that right. And this is also another patient of ours. As you can see, the slides are from my colleague, Professor Venukavathappu, and you can see significant debridement, washout, long time with VAC therapy, and this is the end result after a few weeks. Still not perfect. We still have to do a lot of work on this chap down the line. He probably has an inversion deformity, which we can correct now. We often plan that, but yes, we've managed to get there after a severe infection. And it's all about the quality of debridement, and debridement is important. And you can see here, if you can get a good infection control, achieve that. And all it took for us for this particular case, as you can see, is 2 months from that foot to this foot. 8 weeks, that's a really, really fantastic response. But ischemia and vascular disease is a big villain. But when there is a severe infection, it's all about infection control. But we do need good revascularization techniques if there is ischemia, because it's a huge metabolic defect, and without getting good blood there, good consistent blood there, often you can't get wound closure and wound healing. And we have a well-oiled team that can do very aggressive angioplasties, repeat angioplasties if needed, pedal angioplasties if they're desired. And also our surgeons are able to bypass both, the standard fem-pop bypass, but many of our patients often require diabetes is a below the knee vascular disease often, and we can do distal bypasses, ultra distal bypasses down to the pedal vessels, and they help us control the blood flow and the need for aggressive management of these patients. Now, what happens when in our center when we have patients coming with severe infections? And this is our own look into our work of 18 months follow-up for all patients with a severe foot attack needing surgical debridement. And we looked at 4 outcomes, and we looked at the first outcome reached: did they heal? Did they not heal? Did they die? Or did they have a major amputation? And we did really remarkably well. For all these severe patients, despite that, we only ended up having to amputate 6% of our patients. Remarkable for this group. These are not the standard diabetic foot ulcer patients, the severely infected patients. We really got 2/3 of them to heal. But you can see a lot of our patients over those 18 months, despite this attention that we gave them, died. And only a 13% or 10% did not heal at all, but they were still alive and coming back to clinic for follow-up. We have the same villains. It's the negative predictors are older age, very high CRP at presentation, being on dialysis, and having, of course, severe arterial disease. Interestingly, having a minor amputation wasn't a part of the negative outcome, partly because I think a lot of our patients did have an amputation of some sorts, minor amputation, to control all the infection. And we mainly at King struggle with a mix of gram-positive and gram-negative infections in this cohort. We are a tertiary center. We take patients from everywhere. But I think in some scenarios, and I was looking at a paper from India, there's a predominance of gram-negative organisms. And I looked at the Latin American data that Gabriela Caro published quite recently. Even in their center, in that region, lots of gram-negative organisms as much as gram-positive organisms. What we found is that despite whatever we did, the first outcome reached of death was achieved in 24% of our patients. And if I looked at the whole cohort, even in those who went on to heal, another 15% went on to die. So ultimately, at the end of follow-up, we had lost about 40% of our patients. And I was very surprised. These patients received so much of intensive support, so much of intensive care, yet many of them went on to die. And that has really taken us by surprise. And we're trying to look into what is this really, that a severe infection is a mortality risk on its own down the line? Is it because they require all these multiple interventions that increases your mortality risk? Is a severe foot attack actually a predictor of mortality in the next few years? I mean, this is experience from one center. I would like you to all look into your centers. What happens to the ones who have a severe infection in the next 18 to 24 months? But it's all about providing, at the moment, this umbrella of care. The screening, the early recognition, getting them to a specialist center, and that specialist center having a good clinical algorithm for rapid treatment of infection, and also recognizing the shock or the critical ischemia and dealing with it. Those are the key things. And like Anna Begonia said earlier, no single person or specialty can manage the diabetic foot. We have to work in teams, and the teams are getting bigger and bigger these days. There are some key members, but without every member of this team, it's nearly impossible to provide that robust support for our patients that they deserve. So, dear chairman and everybody in the audience, the diabetic foot attack transcends any classification of diabetes, neuropathic or neuroischemic or purely ischemic. It's a severe presentation where you really need a protocolized management with a team that knows how to run the ship in an aggressive sort of way, much like how the cardiologists and neurologists run heart attack management and stroke management, or a trauma pathway. Infection control, when present, is always primary, but you really need a large multidisciplinary team to look at it. I'm really surprised with the mortality risk that we found in our core group, and it certainly requires further inquiry. But at this first meeting, all of us, I think we should come together, collaborate, understand what our patients need, develop protocols, and we need to understand outcomes in this core group. This is probably the biggest group, and probably the group that gets talked about very little, because that is what will help us prevent the key amputations and save lives. And like William Shakespeare said, it's better to be 3 hours too early than a minute too late. On that note, I would like to say thank you very much to Professor Rizola for inviting me, and a great congratulations for developing such a fine program over 3 days that people can sort of dip in and understand and pass the message of diabetic foot management. And I hope to see many of you in the diabetic foot study meeting in Bratislava this year. But if you really want also taking a deep dive into managing the complex Charcot foot, we would welcome you. It's a face-to-face meeting, so if you are in Argentina or something, you would have to come to London. London's a great place to visit in June, but this meeting next in 2 months, on June 24th and 25th, is our limb salvage meeting here at King's. But again, thank you very much.